this and pass it over to Patrick to go ahead with the presentation.
Well, thank you so very much. First off, let me say I'm absolutely delighted to have this opportunity to be able to talk to everyone today about these methods, propensity scores and disease risk scores. I think they're both topics, and they're topics that I think have garnered a lot of interest. And so to go ahead and dive into today's topic, just a little background. I was at Vanderbilt, for 11 years, and I just recently joined Kaiser Permanente out in Portland. So I'm new to the group, but anyway, so just a little back there. So just a brief outline. So I'll talk about just, again, I think most people are going to be familiar with what propensity score. I'll talk about what is a disease risk score. Again, two methods that are similar in spirit. I'll talk about the benefits of both analytic strategies, and then talk about situations where you might consider one versus the other, and then kind of wrap up with a summary. So to motivate today's talk, again, in the setting of observational studies, we need to adjust for a very large number of confounders. So, a common situation that I find is that, if you have a observational study looking at cardiovascular disease, and you're dealing with an electronic healthcare database, so you have the benefit of being able to access a particularly large number, or more medications or comorbidities, and you could adjust for these individually, but sometimes that may not be feasible, or trying to pare it down to a more, say, parsimonious model may not be the most realistic approach. So we need to consider options. So one option and I know it's been presented already a bit, is what's called the propensity score. And so if, say, you have a binary exposure, you're exposed to the drug of interest or you're not, the propensity score is going to be the probability that a person is exposed to your drug of interest conditional on their individual covariates. So this will be conditional on age, gender, income, so forth. And this was proposed by Rosenbaum and Rubin in 1983. And now this can be applied, again, typically it's applied to an exposure that's either you're exposed or unexposed. But it can be more generalized to where you can apply it to exposure of, let's say, multiple exposures. It's kind of a newer area. It's an area that I think going to be growing interest in terms of comparative effectiveness research, and I think there's a lot of in that area, and I think there's a lot of future research in that area. But at this time, it's the main applications have been in more the binary setting. In terms of applications, you can compute probability, and you can either adjust for it as an individual covariate instead of individual covariate. You just use the propensity score as a covariate in the regression model, or you can match on it, which is a methodology that's growing greatly in terms of application, or weighting. The benefit to the propensity score is that it's particularly useful when you're looking at a event, which is not uncommon in comparative effectiveness research, and you have an exposure that's maybe more prevalently used. The idea here is that it's going to improve model stability because, instead of trying to adjust for, say, 100 individual covariates, you're adjusting for one covariate. All the nice benefit of it is that you can look at how well those individual covariates predict, the likelihood of receiving the exposure, and that's quite useful. Again, an area of, I think, of clean application is matching on the propensity score, because it's been shown that you can get better balance in covariates. In my next example here, which is, it's basically a comparison of different propensity score methods to show, that there are situations where, again, I think shows kind of greater utility, and which is why I'm kind of presenting here. So this example is an example by Toby Kurth, New England Journal in 2006, looking tissue plasminogen activator and patients who suffer from ischemic stroke. looking at the Westphalian Stroke Registry. So it was a large registry, about 6,000 folks. And what they did is they applied several different propensity score methods. They adjusted for the individual covariates, which is more standard approach. Then they did matching. They adjusted for propensity score and weighting. So here is what is the distribution of propensity scores between those who received and those who did not receive TPA. Those who did was a small group. It was 200 out of over 6,000. So it was a small group, but got a pretty healthy disparity in terms of propensity score distributions. And when you have a full cohort, this column here is that very different results. So we look at the unadjusted folks looking for individual covariates versus change of potential applications. We get very different results. The point of hearing this is that it's when you apply propensity scores, you need to be very thoughtful in how you apply them. Because one of the things, I think one of the values of this paper is that when they exercise trimming, where they restrict patients with propensity score of 0.5 or greater, have much greater consistency, which is this column here, which I'm going with the highlighter here. Results are, again, much more consistent. I felt the value of this paper is to demonstrate the value of matching in this particular setting. So, those propensity scores. So, the disease score is another option, which is similar in spirit to the propensity score, in that it is a summary measure that is derived using a regression model. Instead of relating the exposure to the outcome, or relating the exposure to the covariates, it relates the outcome to the covariates. And two variations on this approach. The original approach, which was presented by Miettinen in 1966, was a regression model relating the outcome to all the covariates and the exposure, but then you took the resulting model and you took the values and you assumed everyone was unexposed, and the disease, that was what he the confounder score, and he did that to everyone in that, assuming they were unexposed. Wayne did some original work on this, but he and I did some supplemental work where we looked at the setting where if we just restrict to the patients who were unexposed and execute that final model for everyone so that they are exposed. So a little bit variation, and then you include in the regression model instead of the covariates. And like the propensity score, again, kind of the application is to adjust for it instead of the individual covariates. The benefit of this setting is that we found it to be particularly useful when you have a very influent or multi-level exposure. And I'll give an example of that shortly here. Also, and like the propensity score, it is a single summary measure. In this case, it summarizes baseline disease risk. And one thing that we found particularly useful is that you can look for effect multiplication by baseline disease risk. And let me give an example of that here. A study published by Ray and colleagues in 2001 looking at antipsychotics and risk of sudden cardiac death. It was a retrospective cohort study looking at Tennessee Medicaid enrollees. It was a large cohort, so 500,000 enrollees with over 1 million person years of follow-up. And what they did in this study, they compared low and moderate dose antipsychotic use to non-users. One concern was that association might vary by baseline cardiovascular disease risk. So what it was, they computed a summary cardiovascular disease risk score based on hospitalizations visits, physician visits, and cardiovascular medications, and plus a model comparing cardiovascular disease rates in non-users, extrapolated it to everyone, assuming they were a non-user. And so here on this table is that if you look at the rate, in particular, the last column is the estimated additional sudden cardiac disease events that those that have a severe cardiovascular disease risk there was a much larger number of estimated events. And so we found effect modification like that, which, again, benefit of this particular measure is that if you have, say, 100 medication comorbidities, you might not be able to sum that, looking at all those measures, but if you can collapse into a summary measure, which is what in here, we can ascertain the effect modification by just, again, baseline disease risk. So to present a much more recent example, so I present a couple of papers here that were published. Was in the New England Journal of Medicine, one in JAMA. There were two studies looking at ADA medication use and risk of serious cardiovascular events. Both retrospective cohort studies used electronic healthcare data. We data from 4 sites. So we used 10 Medicaid, Washington Medicaid, California, and Optimum site. We had a study where we looked just at children, and we had a study just looking at adults. Our study included 1.2 million children and adults with over 2.5 million person years of follow-up. The adult study included 400,000 adults and with 800,000 person years of follow-up. So and this is all joint endeavors. Bruce, are you on this call by chance? If you are, just let me know. But Bruce Fireman was also one of your statisticians involved. So, Bruce, if you have any feedback, please feel free to chime in. So on the adult study, let me start with the child study. So within 4 outcomes, looking at sick death, acute stroke, or the outcomes. Again, in the child study, you're not going to have a lot of events. So we had, out of our large cohort, we had only 81 events. And exposure was looking at either non-use, former use, current use of ADHD medications. And so we were dealing with a very rare outcome, and our outcome was expressed as a much more prevalent outcome. We decided to use propensity scores in this study. Excuse me. Again, same outcomes, but in the adult study, we had a lot more events. We had over 2,000 events. And what it gave the latitude to do was to look at medications at a much more greater detail. And we had base level exposure. And so what we decided to do there was let's use risk score where we compute it separately for each outcome. But again, with a level exposure, you'd have to compute 7 propensity scores. So we decided to go with these risk score in that particular setting. Again, kind of the reason why one approach versus another here. In terms of much more head-to-head examples, great study published by Tilsteiner and colleagues in 2005 in the American Journal of Epi. This is where they looked at propensity scores and disease scores, and looking at antibody use and when your all-cause mortality. We adjusted for all the individual covariates. They also then adjusted for propensity score, the education, matching, expression adjustment, weighting, and included a disease risk score. In a study, which again is the situation where you're typically going to incur here, were over 100,000 Medicaid beneficiaries, a number of confounders, so the 81 confounders. And for analyses, they looked at the full cohort, but then employed some resampling schemes where they sampled 10,000, 1,000, and 500 persons 1,000 times, and that the results were pretty much consistent across the board. So there's a little difference. So, okay, situations where the propensity might be preferable to the disease risk score. If you're dealing with a rare outcome and a common exposure, I think it's been pretty well demonstrated that the propensity score is a better approach. Also, a nice benefit is that you can look at that are more predictive of exposure. The matching, I think the match is being shown more and more to be better balancing covariates. One thing to bear in mind is that when you have multiple outcomes, the propensity can be beneficial, but one thing to bear in mind is that if you have multiple outcomes, that you need to be mindful of covariates that are related to the exposure and may not be related to the outcome. So you want to be mindful of that. It's been demonstrated that in Alan Brard in his great paper, Don Rubin looks very well in his paper in the Annals of Internal Medicine, that if the covariate is only the exposure of the outcome, then you might have potential bias. So I think you need to be mindful of that in this application. But again, there's still great utility there. Where the risk score might be a preferred approach is if you're dealing with an exposure that maybe is multi-level, again, like end stage, where you're going to look at individual end states, or I'm going to say looking at antidepressants right now, which we're looking at individual antidepressants, and so you need a propensity score for each antidepressant, so you need to be mindful of that. If any of them are infrequent, the risk score might be a little bit preferable when you're looking at just a single outcome in that setting. Certainly, if you have effect modification by baseline disease risk, I bet this is a useful tool. And again, kind of value is that you can see risk by exposure group, but also by outcome group. So just to give an example of, when you have a situation where you have a multi-level exposure and cells might be a little bit infrequent. This is a study that was published by Dave Graham and colleagues in 2005 in the Lancet, looking at end stage and risk of sudden cardiac death. It's a case control study, so it wasn't a cohort study, and I'll comment on that more in a sec here. Using data from Kaiser of California. 8,000 cases, about 30 controls, so about 4 rows per case matched on age, gender, and health region. So the exposure, the exposure levels were looking at individual end states. So you looked at low dose and high dose. High was the medication of interest. I also looked at celecoxib, ibuprofen, naproxen, other NSAIDs. And then the other groups were recent use, which was, if they quit using within 60 days, versus the reference group, which was called remote users, which were those who had filled the prescription in greater than 60 days. What was done in the study was to compute, again, a baseline to the risk score. Again, it was a mass study, so used conditional logistic regression. And it was a various number of cardiovascular medications and comorbidities to baseline disease risk, restricted to remote and non-user, and remote and recent users. And then was fit the model, compute the linear vector, and then just folks into 10 straight. Looking folks that had no cardiovascular disease risk factors, and then just balance based on the rest of the folks. Results And I want to point you to, well, I've got the little red pointer here. Again, the group of interest were the Arbogast users. So obviously a very infrequent group, 10 to 8 controls. So I multi-level exposure. Target group of interest was very infrequent, so that was motivation for using a disease risk score. And again, we see that there was an important and significant increased association. So this was a situation where I think motivated using the disease risk score versus say a propensity score. Just to kind of follow up on that is there was a nice paper published by Metz and colleagues in 2007 in the Journal of Epi, looking at the performance of propensity scores in case control studies, case cohort studies, and they observed an artificial effect modification by propensity score, and also some potential reducibility of controlling for potential confounding. So, this is a setting that the disease score might be a little bit better, but I have Vanderbilt that's working on this, and that again, it's not something I would totally rule out, but just on bear in mind. Okay, so next about Wing Ray and I, we published a study that came out last year in the Journal of Epi. Did a simulation study kind of comparing the performance of propensity scores, disease scores, to just adjusting for individual covariates and see how they perform. And we set it up to kind of simulate your typical pharmaco-epi study that, again, might use a disease risk score. In this particular application, we looked at 10 confounders. So these are the indicators of comorbid medications. We binary exposure and outcome. And of particular interest, well, two things, but one thing I'll mention here right now is we're going to look at the situation where we have correlation between exposure and confounders, and a situation where we have strong confounding or strong correlation between the exposure and confounders. Because in an early paper published in '89, Goldman observed mutations of the disease risk score when the exposure and confounder were highly correlated. Very so relative to our paper, we did have the covariates were related to the outcome, so we didn't, in this particular application, we didn't consider that situation. I think that would be an area of future research. As we did a situation where you adjusted the individual covariates, we adjusted for a propensity score, and considered the two applications of disease risk score. One, we just restrict to those folks who are unexposed, and then apply, and then fit model and apply it to one assuming unexposed, and then the Menon approach where you fit a model adjusting for everyone you would exposure, but then when you compute the score, assume everyone's unexposed. So with those as well. Excuse me. The other things we also assessed was an important topic is assessing the impact of the number of events per covariate. So we looked at a situation where if we had, say, new events per covariate, which is kind of more the rare event situation, where you had a large number of events per covariate. So we said, well, so here's a situation where we have moderate correlation between the covariates and outcome, and it's all seemed to perform pretty well. Unexposed had a little bit slightly higher bias, but again, it never exceeded 3%, so it was higher, but still, pretty moderate. Since we have strong correlation between the covariate exposure and outcome, again, exposed disease risk had a little bit higher box, but again, still not bad. I mean, it still never exceeded 5%. So it wasn't bad, but it was significantly higher. Looked at the event per confounder. Again, here is looking at 1 event per confounder up to more than 20 events per confounder. We saw the approaches with, again, the unexposed disease risk score doing a little bit worse, but the bias increasing as, again, the event per confounder getting worse. So again, just to summarize that, what we saw that, as long as there was moderate correlation between various exposure and outcome, I think did just fine. I mean, the unexposed disease risk score a little bit wasn't as, had a little more bias, but again, still not unreasonable. When there was high correlation, the propensity score, or just, again, nothing for individual covariates, seemed to do quite well. But based on the literature, if you look at studies that, empirical data that we collected, that there wasn't, rare to observe a high correlation between COVID exposure. So, so we feel, that approaches are not unreasonable. And again, kind of what I'm saying was that just, again, more traditional approach seemed to do just fine. One of the topics I want to touch on here is, again, I think an area that's growing in terms of interest in terms of research is looking at situations where we have a multi-level exposure. So this is more in terms of the area of comparative effectiveness research. And here's one example, was published by Cataract colleagues in 2010, with 4 occasions for preventing notable fractures. And in this study, they looked at propensity scores and disease scores. In their study, again, data from a single study, but still I think it was quite useful, was that they observed that the unexposed disease risk score, again, it's a setting where you compute the disease score amongst those folks who are just unexposed, for everyone, assuming everyone's unexposed, is the greatest bias. But they commented on the fact that baseline disease risk varied by your exposure group. So this is a situation where it's really probably not surprising that the unexposed risk score didn't do as well. And again, our relations kind of mimic that. So I think if you had a situation where base risk was kind of more or less consistent across your exposure groups, you have more consistent results. To summarize here, situations where you might want to use one or the other, again, depending on the application. There's a lot of settings where you could use or, and I think it would work just fine. A couple of papers. There was a great paper by Till Starmer and a paper by Dave Graham, great papers, where they observed consistent results where you either tested for the individual covariates, just using propensity scores or disease risk scores, and you have the results. So at this point, I've not seen the situation where these summaries were necessarily, give you more consistent results. Not that couldn't occur, but I've just not seen it yet. But the nice thing about them is that they provide some information that you don't normally get that I think is quite valuable, and I think consider either or both. I think in your particular study, and just mention areas that touched on in this presentation, but I think are of value is, for example, the high dimensional propensity score is a methodology that I know is growing greatly in interest. Because I've been live here recently, so I think that's what I've not looked into in terms of valuing, but I've had the opportunity to apply it a bit, so that's been great. Matching on propensity score, disease risk score, I think is another area. And then again, looking at the area where you have a multi-level exposure, where you're going to, again, more of the comparative effectiveness research that I think these methods might be particularly useful. So yeah, I think of future research, and I know I'm looking into it a little bit. I hope other folks are looking into it. And that's my presentation. Here's just a list of references that I mentioned that I think are of value, and that spiel, and I am happy to entertain questions after that. Thank you.
Thank you very much, Patrick. I'd like to open it up for questions then. Did we unmute all of the lines?
I just unmuted everyone, so if I'm not hearing any feedback, which means everyone's probably still on their own mute, but the phone lines are now open for questions.
Okay. Well, while people are thinking about questions, I had a couple of thoughts as I listened to your presentation, Patrick. The first is about transparency. And so in the presentations about the propensity score that I gave, and then also that Till gave, as well as John Brooks, there were a point was made in a couple of different ways about some of the value of the propensity score with respect to transparency. And so there's value in transparency with respect to how you can present, say, for example, a table 1 that shows the characteristics of the population before matching and after matching, and you can see in the after match cohorts there's a very high degree of similarity on all these different characteristics, so I could trust that the follow-up of these groups would be unconfounded. There is a similar aspect to transparency that the disease risk score could provide. Can you comment on that?
That's a good question. I would say yes in terms of get folks that, again, you could, compute the summary, the summary disease risk, you set that between those who, have your events, say, sudden cardiac death versus who don't, you look to see, how different are they in terms of baseline disease risk. So that, I think that gives you a starting point, similar like the propensity score. So you look to see, if there are inherent differences, you can not acknowledge it. I mean, in terms of you can account for it, in and of itself, but at least you can know what that baseline disease risk is. So I think there's value in that. It's a little different than, like I said, the nice thing with the propensity score is that, like you said, especially when you match on it, counter results that are similar in spirit to the trial in terms of you can look at the balance and covariate distribution between your exposed and exposed groups and ascertain, balance. You can't do that with the disease risk score, but you can retain disease risk. So if that's something that's concerned, you can at least quantify it, which I find valuable.
Other question? I have actually a related question on the transparency angle for just a minute. So one of the things that I often do with when I do propensity scores, I graph the propensity score distribution among the exposed and among the unexposed. I can see visually the areas of overlap, and so I know that I either have to trim or just restrict to the area where there actually is overlap. Is there an analogous diagnostic approach with the disease risk score?
Great question. I'm not aware of one, but I think it needs to be looked into because I think that's an important point. That I think if you have with greatly varying disease risk, I think you might want to try to. You might have to do more than just include, like propensity score. You can't just include as a covariate. That you might want to do for the trimming. I've not had a chance to look into it yet, but I think it's an area that needs to be looked into. So that's a great point. So if there's any looking into it, or like I said, I might come up to 3 times. I can look into it. I think that would be quite valuable.
All right. I have another question, and this is related to automated surveillance, such as active comment. Hello?
Hi, you're cutting out a little bit there.
Okay, I was curious about the use of the disease risk score in an active surveillance framework. That is, can you think about situations maybe where the disease risk score may offer advantage or disadvantage in the context of automated surveillance of new pharmaceuticals, for example?
I think so. I mean, I think it's, gosh, if I remember correctly, Glenn gave a talk at the ISPE meeting last summer in Chicago. We'll talk about the potentiality of, if you know baseline disease risk, that if you have a new medication out and if risk might vary by baseline disease risk, that you might give it different groups of folks. And I think there's great potential in that. Like I said, I haven't had a chance to look into it yet, but like I said, he gave a great talk about that as utility. So yeah, so I think there's great potential there.
Any other comments or questions from the audience? All right, so I'd like to preview that next Decide Learning Network is about healthcare delivery system evaluations. This will be next month with Steve Sumrai. The following month we have Johnson from Pfizer, who will also talk about some challenges in predictive modeling. But otherwise, thank you very much for everyone's attendance.
All right, well, have a good one.
Thank you, Patrick.